All right, so we're going to get into some more exciting stuff that is entirely optional for you to focus your attention in on if your goal was just to learn about basic 12-lead EKG interpretation for ST elevation MI. This is all stuff that I think is very useful, and it has its place, and it's all a matter of what you need for what you're going to be doing. So consider this is not something you need to know. This is all additional content. I just want you to be well prepared wherever you're going to work, and don't feel like you have to force yourself to learn things if your brain is currently steaming. Then go get a coffee, relax, stretch, come back to it. Make sure the first part up to this point makes sense. If it doesn't, you're not ready to go on. Okay? Once it makes sense, then we'll go on, and you have all the time to continue access this. This is one of those things that you're going to grow in your profession and continue to add to as you go. It's not a one and done kind of a deal. So some of the things we're going to talk about: pulmonary embolism, WPW, LGL, pericarditis, Romano Ward, digeffect, electrolyte imbalances, pacemakers, LVH, Brugada, and then how we can, in fact, diagnose MIs when you have left bundle branch blocks. I know we talked about before, like that's not the safest thing to do because a lot of times you think everyone has an MI when they have a left bundle branch block. There are a couple ways you can actually diagnose that, so we'll talk about those. Lots of nice little tricks to have in your back pocket. So PE is probably the most useful thing that we could talk about because these are situations where people come in with having chest pain, shortness of breath, stabbing, isolated chest symptoms, and they typically have a story that makes sense with it, like they just were on a long flight, or they were just sitting in their office chair for a long time, or they just had surgery, had a long bone fracture, or just gave birth to a baby, an amniotic embolism, fat embolism, all the possible embolism etiologies you could have. I will just make you think about this one quick thing. People go, I wonder if they had AFib and it caused it, or they had a stroke or whatnot. Keep in mind that is most likely not going to be something that is in the same system as the arterial system. This is all a venous system issue. This is somebody that had something embolized from a thrombus somewhere in their system, most likely from their legs. Deep vein thrombosis is really where we get into trouble, and our legs are our source in many times for this. So just always be on the lookout for that. Telltale S1 Q3 T3 is a finding on 12 EKGs that can give you a really good idea, is this a PE versus if this is someone with a true STEMI. Just like we talked about pericarditis before as our first practice question, you go, what in the world is that? Everything's elevated. Well, yeah, if you see that, it makes you go, wait a second, this probably isn't a STEMI, this is probably something else. Same thing goes with PE. If you see that S1 Q3 T3, you should go, wait a minute, something's going on here, and I don't think that it really looks like an MI. It looks like something else. What's going on here, when you have an S1, that means that your QRS is actually negative in lead 1. And as you think about that, that just means that it's swung towards a rightward axis. And as you see below, it says motor diagnostics when paired with right axis deviation. Well, if you have an S1, you definitely have a right axis deviation, because for it to be negative, it has to be greater than 90 degrees on our unit circle, which, again, go back to that slide if you want to use that for reference. But the point of this is you have most of your electrical energy going from 0 to 90 degrees on that unit circle from the 3 o'clock to the 6 o'clock position. That's a normal vector of the ventricular impulse. If it's swung to the right, we go, why is that swung to the right? Do we have something mechanically pushing us that way? Or do we have something physiologically drawing more energy that way? Do we have chronic hypertension of the right ventricle, which is cor pulmonale? That very well could be an issue, but people that smoke or have pulmonary hypertension or idiopathic pulmonary fibrosis or cystic fibrosis, these are things that we know are going to cause you to have increased PA pressures that push back into the RV and cause dilatation. When you have that happen acutely, though, that will cause some strain, and the heart's pumping and it can't get it out and is going into the pulmonary artery, but there's a blockage. So you have a big saddle pulmonary embolism where the PA forks off to each lung. That's a pretty common spot to have a very concerning PE. Sometimes you have small, they call it subsegmental PEs when they're out in the branches, so to speak. But if they're at the base, that's a big deal. Just like the heart, if you get to the base of the branches, that feeds the whole branch, that takes out a larger system. So saddle embolisms are not a good thing. Those are very, very deadly. So that would be a reason for us to say all of a sudden we have an acute elevation in the pressure in the right ventricle. And what's that going to look like? Well, it's going to mean that all of a sudden we're going to swing our normal axis towards the right because we're going to have a whole bunch of engorgement of the RV that's going to electrically have a time and a place. It's also going to have a presence of a Q wave and that T wave in lead 3, and it's going to show us basically where we have extra pressure going on, and it's causing some stress on the heart. So you put together all of that picture, that gives you what you need to diagnose that, and here you go. That's the picture. That's where you see in lead 1, up at the very top left there, you have this area here where you have that S wave that's going downwards. In lead 3, you have the beginning here, you have that Q wave, and then you have, just to the right of it, you have that flip T wave, showing you that you will have some consumption issues going on there. The heart is not happy about this. So the rest of the EKG is fairly benign. You go, it doesn't make sense. They're having chest pain, everything's awful, and then you don't see anything else, but you do see that. You go, wait a second, time out. I have something going on here. This is legit. So always keep this as an index of suspicion. Now, this guy also has a little bit of depression in lead 2, and then also over in AVF. So the entire inferior system, which is fed by the RCA, is being taxed right now. Not good. Part of the process here is just going to be looking through and getting a good diagnostic of those 3 things. And if you see them, it doesn't mean you have a PE, but it does indicate it's pathognomonic for elevated pressure in the pulmonary artery, which backfeeds into the RV. So pretty much going to be a slam dunk if you have someone with acute onset of chest pain and you go, okay, that makes sense. I believe it. So you would probably put this person in a CT scanner and look at their chest and say, okay, what's going on in your chest? You'd probably find that they have, with a angiographic dye, a pretty large thrombus that has embolized and become a saddle embolus on the lung and in the PA rather. And that's all it takes to get a good diagnostic. So point is, you don't have to do a 12-lead EKG and take them to the cath lab to find out plenty of other stuff. And this is one of the most common things that you'll find. So it is there to be your friend. Now, one other thing here that they've mentioned here that I think is worth noting is that you have a flipped wave when you get into the V1 here. This is giving you a flipped P wave the other direction. Nothing to get too excited about, but sometimes you will see atrial enlargement too, and then the atrial enlargement will show up with an enlarged P wave, or sometimes you'll see a little double bump in there. It's called P mitral. However, not what we're seeing precisely here. This is someone that this is probably a fairly acute thing, but some people do have this chronically. It gets worse and worse and worse, and they just have massive RVs. Just keep that in mind.